Yes, now it's okay.
Perfect, 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 perfect. I'm so sorry about this. So, as you can see, there's a considerable wear. There's a lot of chipping teeth. There's an old crown here and there. So, patient does wear a partial maxillary denture. I think there's a mandible. I'm not quite sure, but it's been there for a long time. And she's 67, and finally she decided to do something about her teeth because she felt that really she can't chew properly and things are breaking in the mouth. And she smiles, it doesn't look right. So, has been two other colleagues as well, and she thought she'd give me a try and see what I think. Well, the problem that I see here, and from when I look at this patient, is the main reason we need to understand what is the reason this patient is present in your practice. One could be aesthetic, and I accept that. But a lot of the time, it's a functional issue because they really need to chew and feel comfortable with what they eat. That's really, really important. This is long-term needs. And the second, we see, like, as you can see from here, I had a lot of work done in the past. There's a lot of fractures. There's a lot of tooth wear, as you can see later on. But she really wants to improve function and the comfort. Hasn't really talked much about aesthetics, but I can tell you what, whenever you treat those patients, you need to really get that aesthetic also back into the program of her thinking, because once you start improving things, the whole aesthetic part comes into it and they become very demanding. So we need to talk this a bit more later on. So the idea is to have a comprehensive discussion. Comprehensive discussion is to find your clinical findings, to discuss the clinical findings of the patient, naturally, and then you look at your diagnosis and your treatment option, short-term and long-term. A lot of patients are used to, for instance, having a dentist come in and fix the problem straight away, but that's not always the case, as we all know. Let's go on next slide. You can see this particular patient, for instance, she's smiling, and there's a lot of issues here, a lot of complexity here. And my work as a specialist is not to complicate things. A lot of us think that, oh, it's complicated. The idea is not to complicate the treatment. If you say, well, you know what, we can do an implant here and an implant here, and they're going to close the gap, well, that's incised or central incised, somewhere it's quite far out there. How are we going to close this space, and now where are you going to put the other two? There's a lot of missing teeth here, a lot of drifting teeth. Maybe they're congenital missing, we don't really know. But what we really know is that this patient is presenting in your practice and is not functioning in shorter dental arches. In other words, she does not have two, sort of occlusal tables on both sides. Could be premolars, it could be molars. That is important for normative function. It's actually functioning on less than 5 teeth across the arch. So it becomes now, in this case, a normative need. What a normative need is, people need to have a functional improvement. If they don't, there will be further deterioration of dentition. So we are very well justified to say, look, you know what, no treatment is not an option. So that's important to understand when we talk about no treatment is not an option, because we need to accept that. Okay, we need to accept that. Any questions so far that you would like to ask the patient, for instance? Shall I go and pick, or maybe Kathy would like to ask a question?
I would ask why is she here? What is bothering her? What is concerned?
The concern was she can't chew properly, and teeth are breaking away, and she's sort of a bit embarrassed about a smile. Her sister actually referred her to me. We did restore her sister's teeth. Had a similar situation, but had lost more than teeth. So she wants an immediate improvement. Actually, the person who came with her was her husband. He wanted to see her looking good. So he's had enough of, the smile, basically. He was like, can you fix my wife's teeth? So that's a nice thing to do. I certainly give him a medal for this, but that's another story. Any other questions you would like to ask this patient?
How can I serve you?
How can I serve you? Okay. Well, patient says, can you fix my teeth? The question is to really think about this case very carefully, because it is a complex case. It's not a simple case. Okay. Now, if you tell this patient to restore your mouth and it cost you all these crowns and bridges, maybe implant there, we're looking at a huge amount of money, which people can't afford. So that's probably what's been said before for this patient. And she sort of let things go for a while, didn't do anything about it until it's like a sign of desperation. And she said, look, why don't you go and see Sarkis? He's done something for me that was quite good. I'm comfortable. Maybe he can do something for you. So she's here for some sort of treatment. Doesn't know what it is. But we need to sort of make her understand the important things. So what would you do for this patient prior to doing, like, to starting any treatment or promising patient? Well, what would you, the first thing would you do? Would you consider like a, examination and then general charting, some sort of an X-ray? And what else would you ask the patient? What sort of question would you ask the patient? I'm just thinking, what would be one question I'd like to ask this patient that will give me lots of clues?
I would like to know what expectations she has, apart from that she will be able to choose.
Okay, that's one.
Kind of how far with the complexity of the treatment she's prepared to go and invest money and time and her being there to achieve the results. So sort of cosmetic expectations, well, that was not an issue, functional expectations, and how far she wants to go. And also what was the past care of this patient, just, how dedicated she was in a dental care over the period of her life to allow such a collapsed position.
Right.
Because I think that time and money invested in making this case really good, you need to have patience on your side.
Right. Okay. One other question is Isidore. Are you there, Isidore?
Yes, Sarkis.
What else did you ask this patient?
I'd ask about any potential dietary habits that may have caused significant occlusal wear.
Okay.
I'd ask if there's any parafunction at night, any chance that she knows that she wears her teeth or grinds.
Okay. Okay. That's for before Kathy's question, but I'd like to know something else. Anybody else wants to? There's a specific question I'd like to ask the patient that unravels a story. Like, there's a saying, everyone's got a story to tell by one volunteer. So how do we make these patients volunteer their story? They've got a story to tell by one volunteer. What would you say that will make a patient open up a bit? Now, this is a very important part of the initial assessment and diagnosis. Let me see. Vivek, your turn.
Doctor, I think I would ask, when did you start noticing the recessions and deterioration of your teeth? Was there any changes in your diet or anything?
Okay, that's a good question. I want a bit more. I want Christina Howard. Would you come into it? Are you there, Christina? Okay, now who else we got? Okay, we got Shraddha. Are you there?
Yes, I'm still thinking.
Says one question, let me help you. What I would ask the patient is, how did you lose your teeth? That'd be my first question. Okay, and they'll say, I lost his teeth because they're usually fractured. They used to get decayed and fractured. I mean, she's 67, so she has never had a fluoride. I mean, she's from Iran, and poor dentistry would be part of it. She definitely has been a history of bruxing. You can tell. There's no question about that. Do you think she's still bruxing today? You think she's still bruxing at age 67?
Sorry, what was the question?
Do you think she's still bruxing at age 67? She definitely has, been bruxing in the past.
I can make a part.
Yeah, 100%. She is still bruxing.
I can make a part.
Okay. Well, let me ask you another question. Okay, so the question is, why do you think she left it so long to do something about her teeth?
She lose them all.
But why did she leave it so long?
Children, Dr. Sarkis.
Children, thank you. All right, that's right. See, mothers look after their offsprings for a long time, and today it's even longer. And so the last one on the line or in the line to be treated. So she found a window of opportunity to come and have a treatment done. So if he caught this patient a huge number of major reconstructive wear, which we entitled to say, there's a chance that she'll let her mouth deteriorate because eventually she'll have overdentures or full dentures. So she will continually, in this case, probably she might still brush and break those dentures. She'll be very uncomfortable the rest of her life. So we need to do something with this patient to be able to restore her function and also natural aesthetics and natural comfort. So she's functioning ESDA, which is an extreme dental shortened arch. You can see it's basically from canine, which is fractured part of the incisor, all the way to the premolar, understanding that there's a missing tooth here somewhere. And what do you think will be the first thing that happens to this dentition next at that point of her coming into the surgery in the next 3 months? What will happen? Which tooth do you reckon is going to break from here? Which tooth will break initially? What do you think? Any suggestions? There's no posterior support anymore. Which tooth is most likely to break the next few months of this patient presenting if we did no treatment for this patient?
2-2.
3-2 or 2-2?
2-2, yeah.
2-2, which is one? You mean that's 2-2 or that's?
Apologies, 1-2. The
1-2.
ground, 1-2.
Exactly. Why 1-2? That's the correct answer. Why 1-2?
It's got a crown.
No, one more.
It's a very small tooth.
I want more than that. I know it's the answer is right, but why 1-2? Number of reasons.
Very small tooth, very small root structure. Crown's already taken away the majority of the tooth structure. And
Right.
It's also partially erupted. It's longer than the other teeth, easier to touch and make contact.
Okay. Let me ask you another question. That's a good answer. You said it's partially erupted. Do you think it's actually partially erupted? This is a metal ceramic crown, been there for probably the last 35, 40 years. You think it's partly erupted, or it's actually in its original form since it was cemented a long time ago?
You're right. It could just be recession, and there's been wear and tear of natural dentition and not porcelain.
So when you're restoring this tooth, which is your guide?
The gingiva.
Right.
Well, actually, that is incisal edge. If that's the original, it would probably be a very good guide.
That's right. So 1-2 is your guide, correct?
Yes.
Yeah, that's what I'm looking for. You see, this is what I look at. I said, that's interesting. That is intact. So I would look at that tooth and build a whole smile line, a whole occlusion line based on that tooth. Does it make sense? So there's a lot of gifts here that we don't see. I also see the position of the premolar here on the left side and the premolar there. Okay, in more or less she's got reverse smile line, hasn't she? Would you agree with me? Looking at the left picture. So what I would do in this case is that I would initially do naturally caries control. That's part of it. I would do periodontal charting. I'll take my x-rays, make sure there's no pathology. I'm not showing you an x-rays today because there's no need, it's not required. And I will stabilize the situation. But also based on that, assuming that there's a component, maybe she doesn't take much medication, but unless there's a style and gold, whatever, I'll also carry on remineralize and put the patient on a large program. But one important part is the early risk assessment for this patient and diagnosis. And this is a thinking game I want you to start to sort of, in a way, understand before you approach these patients, before the patients open their mouth and you examine them. The last thing in my armamentarium, when I'm actually discussing examining patients, is to understand you need to have a philosophy of treatment for an optimal outcome. And naturally, there's only one diagnosis. There are many treatments out there for only one diagnosis, okay? And based on your diagnosis, we need to ask ourselves a very important question. That is, doctor, can you deliver? And I'm playing this is like a playing chess sometimes, because it's not about delivering the dental treatment, but actually looking at, like Kathy said, expectations of the patient. Because I look, numerically can't give you a third view. I would be very careful with that one in movements because we're being very nice to the patient, but you don't really know where this patient's coming from. So part of the diagnosis actually depends on us talking to the patient. I bring the patient a couple of times until I'm really comfortable that I can really look after this patient. And that's really, really important because the last thing I want is any preconceived notions, any other expectations which didn't come about during delivery. So having said that, what I would, let's say we've done a diagnosis, okay, and we've done a diagnosis. What would you do next? Now you've done your diagnosis, you've done your clinical tests, you've carried out all your clinical tests, like study models, talk tests, periodontal charting. You might want to do, in a periodontal charting, mounted models. You got your X-rays, and you got, all the things. What else? What would you do then? What would be the next thing you would do for this patient?
Quick mock-up to win her confidence and show her that there is a hope out there.
Okay, that's very good. We can do the mock-up, and I agree with that completely. But before the mock-up, what would you do as a part of your initial assessment and your diagnosis? Like before the mock-up, would you have a dialogue with the patient to sort of explain?
Yeah, it's going to be a video, short clip, and check her smile line and everything in a motion. So while she is talking, while she is smiling, and every single angle, to just have a rough idea, so we can actually see what's the final vision like. Because you got a reverse smile line, you want to probably get the smile line right, you want to see her speech and everything, and just make her feel comfortable. I think it's not too hard to make her comfortable in a first visit, just to make sure that this person has been waiting for years and years to get some right treatment. So we need to get her confidence that yes, we can deliver. And this is what we're looking for. We're not promising at this stage. We're just testing the system. So we want to see where she is, what's her reaction is that what she wants to achieve? And just at the same time, get an idea for us that how is everything going to look.
Let me throw spread in the wheel. She says, "Doctor, I trust you. Do whatever you're going to do." Have you had that happen to you before?
Yes.
And what happens? So, doctor, I trust you. So we've discussed comprehensive discussion, right? We had a good talk with the patient. And this can be done in a separate office with your images, or it can be in a clinic, eye to an eye. And I've especially put this photo because you build up a report now, and the patient's comfortable with you. They allow you to do all this initial cleaning and the X-rays, and that's part of comfort building. There's when patients are like, "I really want X-rays. I really want you to do this. I really want to do it, but I just fix my teeth." To me, that's a red flag. The answer is no. I'm not your practitioner. I want you to see somebody else. And I think that's okay. So we discuss the diagnosis, and that's important. And the other important thing we discuss with the patient from a baseline diagnosis and from the clinical findings and other tests is treatment options and gaining consent, like Nimesh just said. It's an important part of a consent process, because remember, in many times you talk about consent, that no treatment is also an option. So no treatment. The trouble is, we need to expect and explain to the patient that in her case, no treatment is really not an option. Okay, and naturally, having said that, you're looking at short-term options and the long-term treatment plan. That's an important part of this treatment. Anybody wants to make any more comments on this?
What about implant retained denture for the upper?
Implant retained denture. Okay. Well, I haven't discussed the options in terms of the actual treatment. I haven't discussed this. Okay. When you say implant retained denture, upper and lower. Okay.
No, just upper for the start.
I'm sorry, I didn't hear you.
Sorry, just the upper as the initial phase.
As initial treatment plan. Is that right?
Yeah.
Okay. All right. Okay. Can I come back to that? And I thank you for that. Let me come back to that and I'll explain it, because I'd like to talk a bit more about it, and I couldn't agree more with you. I think the important part is for this patient, because you're going to rehabilitate this patient, and you want to establish, I think, I'll come to it in a minute, let me just come to the next stage, and I'll come to that. So what I normally do in this case, what I would think is look, everything can be a logical approach, and you may have your own approach that you'd like to take. It doesn't have to be my approach if you don't want me saying it. So what I do in this particular case, any case where I do, I look at the geometric risk factors, okay? Occlusal risk factors. Those are geometric, like Izzy you said. You've got a lateral that's got a thin neck, short, considerably shorter root that's compromised on past crown preparations. It's going to fracture, okay? There's your occlusal risk factors. What are they? The forces are applying. You're going to say what happened, and if you're going to think about implants, like you mentioned before, bone implant risk factors, we'll talk a bit more about that. Then the technological risk factors, the materials you're using to be able to restore those teeth. So, and the most important about this is the fact that you need to be able to apply this to every tooth and implant supported patients when you're designing implant or tooth supported prosthesis or restoration. That is to get a predictable outcome. So you can't just look at the overall mouth initially, but look at tooth by tooth cases, find out your straight factors, find out what the occlusal forces are, find out how can you maybe redirect these forces before you think about any other treatment. Like, can I save the teeth? Can I design a restoration so I can maintain these teeth? I can always do implants, and I agree with that. But what about implant fails? What is your fallback position? How would you feel when you could save the tooth and suddenly you were able to lost teeth because you used those teeth for the time being, and you lost the implants, and patients left are worse off? That's the question we have to answer. So whenever you think about doing a treatment for the patient, understand what is your plan B. In other words, what is your contingency treatment plan? If you don't have a contingency treatment plan, think about before starting any extensive and very invasive gun-hole treatment. So why we do this? Why? Because you need to ask the question, what's the real cost losing an implant? For me, the real cost of losing a restoration or breaking a restoration, I have a chance to repair it. I have another go at it. But if you really lose the implant, the real cost not just not economical, but it's biological loss of supporting hard and soft tissues that you're going to reconstruct. Now, I have a particular case, and Dr. Nimesh has referred me, and he had a problem with the implant, and the patient said, well, you're the specialist, you can do it. And I placed the implants, would you believe they start failing too? And the reason for that is other factors. Look, there's medical history, a lot of other things. We put him on lots of other factors. I'm assessing him. Slow, let's figure out. Nimesh, you know what I'm talking about. So what's our fallback position? Good thing was Nimesh didn't consider any tooth extraction. He was only replacing what was missing. That's fine. But if he sort of said, oh, we're going to take this tooth out, take that out, then suddenly you go in and put it there, then why'd you take my teeth out? The implants failed. I thought it was fine before you started. So you got to think about why there's too much emphasis on placing implants. The most implants are really important for replacing missing teeth. But number one priority should be to maintain what the patients have. In your opinion, I'd like anyone to answer the question, when would I consider taking a good tooth out to place an implant? In what situations? Can someone talk about it? When do you think I would consider taking a good tooth out and place an implant?
I would normally consider to take a tooth out for a number of practical reasons.
Right.
One would be infection. 2 would be no strategic value. 3 will be difficult to maintain. So the first one, if there's a lesion and I don't see the point of keeping that, then it's better to live without, then that will be the first one if the patient is in pain. The second one with strategic is that if I can use it for any benefit in terms of establishing a occlusion or to actually support what is there, even just maintain the contour of the alveolus bone, I would consider to keep it, even if I decide to bury the root. Number 3 would be more long-term, because no matter how good my work is, if the patient find it difficult to clean and maintain, it's pretty much like you're buying a car and it's going to deteriorate and devalue from the day one.
That's a very good point, Catherine, and thank you for those comments. If I could may add to those comments as well, I think one of the reasons I would maintain the tooth, for instance, even when I'm doing major reconstructive implant work, especially the maxilla, the high smile line, where if you take the tooth out, you go one side's really good, and the other side is basically the alveolus could be lost vertically. So maintain those teeth, even doing good root therapy and even submerging it and allowing the soft tissue to cover. You can maintain the height of the alveolus and you can place implants in between, and that way you have a minimal aesthetic problem in terms of looking at the transition line between the gum and the prosthesis. So that's one important point, and I do that quite often. There's a new concept of socket shielding and all that. That's not much of evidence there. All a lot of people talk about maintaining, but that's the old concept. There's nothing new about that concept. The other thing, the only reason I would take a tooth out, Catherine, and as you mentioned, if it's really I'm doing a major implant support prosthesis, and because of that particular tooth, it's going to affect the design of the prosthesis. If the design of the prosthesis is compromised, that's not going to give me a satisfactory result, and there's a 1 or 2 or even 3 teeth in the way, I'm going to remove those teeth, because certain, especially in the mandible and well, the next bit maxilla, I'm quite comfortable that the implants will integrate. So what I will do then, if it's a mandible, I don't have a problem. I'll take them out and place the implants and load it in. So if it's a maxilla, I will go stage approach, make sure the implants are integrated, and then I will consider taking those teeth out. In the case they don't integrate, there's other issues, I will take the fallback, and that's really important to think about. And it's very important also to share your experience, your feelings, what you're thinking with the patients. Patients just love the fact that you got your heart there, I say, not the mind yet, and the mind in their own interest, and I really enjoy the fact that you're doing it for the patient. Let's look at further this complication. Okay. So we talk about functional risk assessment. You can see that this patient, this is a different patient on top, but you can see there's extreme dental, dental arch, shortened dental arch. So in our occlusal context, occlusion conditions is perhaps unfavorable, and is a reduced restorative space for this patient. That's something to think about. Although patient 67, the wear is not quite normal. There's been asymmetric wear, traumatic wear. No, I don't know if you measure about soft tissue trauma, lower central incisor. I think it's 3-1, impinging on the palatal tissues. And you got a high masticated fossa pelvic fur because teeth are forming intertwined into one another, into digitation into one another, and we have a parafunction. And understanding that if there's any periodontal issues and parafunction, it's just lethal. People lose a teeth. So if you don't see many bruxes who actually got periodontal issues, if you think about it, a lot of bruxes have got a very strong bone to resist tooth movement. They have exostosis, a lot of them on a labial aspect, not just lingual, and that's something to think about. You can see a labial-buccal exostosis, and naturally you have a history of fractured teeth like this patient presented initially. So the history tells you that no matter what you put in his mouth, it's going to break down faster than you do otherwise in a normal patient. Now you have to tell the patient to understand this, because it is important that they understand that it is somehow, if you restore those teeth, it doesn't mean they're going to last for a long time. And you might have to decide to do a number of different options for this patient. And the removable option is not an option for this patient. So prosthesis cracks, partial denture cracks, she prefers not to wear a partial denture, but I need it for a time being initial preparatory phase. So it comes to a preparatory phase. Any takers on what would you do? There's the upper and lower prosthesis, as you can see. She's born. How would you treat this patient? I'm going to ask, who shall I ask? Who wants to take this one? Anyone? Isidore?
Yes. So what stage are we at now, Si?
I know. There's no right or wrong answer.
Well, I think Nimesh had a good suggestion with the mock-up, just to give you an idea of your leveling and your lines and your angles. And
let's assume we've done the mock-up.
Okay.
And the patient's happy. How would you treat this case? Kathy, you're most welcome to come in as well. Nimesh, Dr. Howard, all of you, most welcome to come in.
Well, so from the mock-up, do we need to bring the central incisors closer orthodontically, or did it work out with the mock-up that they looked okay?
Okay, let me answer that question. Patient is 67 years of age. She comes from an ethnic background, and trying to idealize things is not going to be that easy. And she definitely will understand having orthodontic treatment to bring it forward. So the answer is, for her, it's a different paradigm. So we're going to fix it restoratively, and that's something important. I agree with you, by the way. I agree in terms of, see, what's an ideal for us, it's not an ideal for the patient. Okay, let me give you some clue. Let me give you some clue.
Do you want me to talk?
Yeah.
Okay. So I'm going to use the composite to build up top and bottom. Okay, get the anterior guidance, get the vertical dimension right. See, make her feel comfortable with the aesthetic of it, and of course we want to see how much we can open the bite. See, I mean, she has got the dentures on top and bottom. I'm not sure how many teeth are missing there, but we can even make a good partial dentures for the time being. And just make her a test drive. Okay, so we're gonna probably test drive this sort of occlusion for at least maybe a year or two, and if it keeps going for maybe even longer, I want to see how she looks after teeth. I want to boost her confidence. I want to make sure she is cleaning her teeth well, she's coming for regular visit, she's comfortable. So I want to get the first phase with composite build up top and bottom, get the vertical dimension right, get these contacts close on the two front teeth. I think we can play with the composite to make it look better there. And it doesn't have to be 100% closer of the diastema either. She will, because with the composite, I think we can go back and forth to just make sure that she is comfortable there. Of course, those over erupted lower anteriors can be leveled there. And once she is, because I think that that's impinging on that 1-2 there, and that 3-1 in this left central on the bottom. We want to probably just, as you said, she is coming from ethnic background. Okay, little trimming on the lower anteriors is not going to make a bigger of a deal. We're just going to level them.
Well, also I agree with you. Yeah. Also, I agree. And they're not going to be sensitive teeth, those lower anteriors anyway. You can trim them, can't you?
Yeah, this is just the test drive. I mean, if it's a slightly loose or mobile tooth, any of those lower front, I'll put a nice. None of them are loose. Yeah. Okay. Otherwise, I would just put a fiber splint at the back and stabilize them for the time being. All we want to do is buy some time. Let's just check the occlusion, see how she is responding, see how is her bite, see how everything and anything she is gonna fail. She is gonna fail on my temporaries. And let's take that challenge on a temporary rather than put something definitive now, and then we don't have a backup.
Fair enough. Any other comments?
No, that's what I would do.
All right. Well, that's a good point, Nimesh. I think we need to open the OVD, and I agree with that, to create a restorative space. But most importantly, Nimesh, was what is your occlusal protection, as we discussed. So you want to have an occlusal extrusion. You can do a number of ways in this case. You can do the direct mock-up in the mouth, and then you can transfer that to an articulator, and then you can adjust all your stents. You can then carry the mouth and build the mouth and just build the stent to build the mouth. That's actually what I did for the patient. Then you provide a mutual protective occlusion, which you mentioned, Nimesh, I agree. And you want to also reduce the anterior loading. That's very important. So, don't forget when the patient is biting, the more jaw is pushed forward as you create, reduce, and redistribute load. The idea is to reduce and redistribute load. And we want bilateral stable contacts and naturally anterior guidance whenever possible, which is an important part of the treatment. And that's really important. So any other people want to make any comments, or are you happy for me to proceed next slide? Okay, I'm going to proceed. Anyone, any comments? No? All right. I like the fact that if you look at this denture, it's sitting pretty well. So she's using this denture all the time. I mean, she's really loading on this. She likes it. So I'll be more than happy to use the existing dentures as well, because it's sitting quite well. You know, look at the tissue here. It's sitting quite well. Okay. And it's holding very well. So why can't we use a denture? I think I would just rebuild the denture using composites at the appropriate vertical height in the mesh. That's what I would do in this case. Finance is a big issue, so reduce the cost of the patient. So you asked me to do the mesh. Here you are. It's a straight handpiece, so we're just going to reduce this completely. Okay. And we reduce this completely, and voila, we got enough room to play. So we even the occlusal plane for this patient. It's geometry. You want to make geometry, have even planes, then you can decide where you at the canine guidance, where you at all this. We discussed at the college naturally, but just to give you a rough idea. And from here, I can just go and basically build freehand. As you can see, the preparatory phase, we maintain all the enamel as we can. There's minimal enamel left, but that's good enough. What I do I also etch the porcelain on the lateral incisor. And you know, selectively I etch wherever I can. You can see my etch the phosphoric acid going all over the gingiva. Do I really care? The answer is no. Do I need to use rubber dam? No, I'm sorry, I don't. Those people put rubber dam on the show. They only use it for that particular show and posting. In the real life, they hardly use it. That's been my initial assessment of a lot of my colleagues. So basically, here's an issue with good enamel margins, as you can see. You know, I use micro pins. I use the blue pins. Do you use blue pins when you're placing pins? Or use the red ones or the yellow ones? Which ones do you use, Nimesh? Anybody else? Who uses the pins? Who does use pins in your practice? Do you use any pins at all, or nobody uses pins?
No pins.
No pins. So I'm going to, well, I use blue pins, and there's a way to do it so that, I mean, we can't afford not to use pins in this particular case. So I use pins selectively for this patient. You can also see the root caries here, which is evident. So that was also restored. You know, people at that age do have root caries, so you have to restore them. And naturally, once we able to restore them, we also place the patient on a remineralization program to get enamel toughened up, improve enamel's mineral content, so you're able to etch and improve its bondability. You can see how well we've etched the porcelain here, which I was built, and this crown is well constructed. I mean, look how long it's been there. It's good margins, so use it as you can. And it would, so from here, as per diagnosing mock-up, we place the matrix and build the crowns. I mean, the most important thing is to maintain biology, you know, and you know, we have plenty of enamel, and we go into a new occlusion prescription. That's very important. Enamel rhabdoperitosis is also good enough to bond any indirect restorations for this particular patient, but finance is an issue. I need to build the occlusal vertical dimension. I need to test the system, as Dinesh very correctly suggested. And once you've tested the system, you're able to restore this patient, if they wish, to the former glory. And as you can see, we went from here, initial presentation, we used the patient's existing denture to be able to restore teeth and the vertical dimension. There's a reverse smile line. Now, this is my reference point, so I'll be going something like this all along. And I will increase the length of those denture teeth, just so you can use composites. And that's not an issue, not an issue at all. So having said that, we went from here using direct composite mock-up to this one here. And you notice how I was able to build the central incisor quite a bit. So we build this from here down and from here down. We did a bit more. If you look very, very carefully, we actually had another lateral here at an angle as a trick to the tray, which we discussed at college, but we placed the composite restorations of the same patients in a normal fashion. I will still have my pencil marks here, as you can see, for this patient. And this was done without any local anesthesia. You notice that none of this didn't require any, I just don't use local anesthesia at all most of those cases. I don't need to. The pulps are recessed, they're not sensitive. Dentine is so strong you can even etch that. You can see how there's a world of dentine is etched here. And went from here to there. And naturally, we were able to build the lower arch into the lower arch, improve the position, create canine guidance when possible, anterior guidance. And these are the denture teeth over there that was built down using composites. This is all done in one visit. It took me about 4 hours to do this, and very straightforward. Now we've really impressed this patient. Naturally, you improve the mandibular smile line. If you was completely high and arching sort of this way, you couldn't restore the occlusion. You had to modify. Always try to modify occlusion plane so they can meet better. They have the two flat planes they can play and place your guidance in your teeth in that flat planes. There's many ways to look at occlusion. It's not complicated if you know how to do it, and we teach it in college naturally. But you can see it's the anterior guidance, the centers are guarding it, and naturally you can see lateral here. There's a lateral tissue movements on both sides. So we've improved the occlusion vertical measure by about, I would say about 4.5 millimeters anteriorly, 5 millimeters anterior, and then the denture was placed later on to be able to at the right occlusion vertical position. This is the one here. This is just an opening up, just coming slightly forward. You're testing the system. Speech was good. That's very important. Speech is number one thing to test the system. If the speech is not quite correct, then your occlusion vertical measure is incorrect, and that gives you good guidance. And again, let's just go back to the next step. So we have a new occlusion prescription. We did test the system, and the aim is to reduce the risk of future complications. So that is the preparatory phase. This is the important diagnostic phase for these patients. Now, if the patient's financial situations change, we have a template now that we can go and do individual crowns on teeth, wherever. You can see I've modified the existing crown. That's the correct length. I'll just add the centrals to that length and build my whole line, all my reference point based on that first set of incisor. It's a gift. Don't ignore it. It's the most important thing you have. To me, that's the most important part of this whole treatment plan. And this is what we do. And having said that, we got to understand that most patients in this category are just happy with single shade and minimal intervention. What astounds me most of the time is that you get colleagues who spend like 10 hours placing multi-layered composites to show how good technicians they are to place them. It really doesn't really matter in a real life for these patients. If most are happy with one shade, if you can restore all these patients in one visit setting in a good, simple, treatment plan, direct treatment plan, no local anesthetic, okay, one shade is all really need. It's A2, A3, A1. It's whatever you need. I use in this particular case EchoSight. It's a DMG product, and you can't even tell the difference between the restoration of the tooth. It's a simple thing, and I don't have time doing it. Photoshopping is what you see is what you get. I mean, that's what it is. Still, pencil marks are still there on this thing. So it's something to think about, okay? And we understand that the aim of the treatment is simplify, okay? Based on your initial diagnosis of treatment, simplify your initial preparatory phase, and the patient's got time to think about. This is also an important part of the diagnosis. So the preparatory phase is important part of diagnosis, and the patients then gains a very good trust in you because they can see what you do, and from here they then be able to go to the next stage because you have a tested system for a year or so, or 6 months or so, depending on the situation. Then if they really want to proceed, they can find a means to go into the next stages. So having asked the question of dental implants for this patient, I hope I was able to answer the question in terms of, I didn't think of implants at this stage, but if the patient finds it's really important for her, then we can perhaps use some implants over here because we establish it. Implants really serve good because posterior teeth are really badly broken down. They're not going to last long. So having implant for posterior support is actually normative need for this patient, and that would have been the next stage for this particular patient. Is there any questions so far?
Dr. Sarkis?
Yeah.
To go to this mock-up stage, did you do a wax up and transfer it, or you did it all freehand?
Well, this is okay. This is the mock-up was done freehand. I trimmed and restored and maintained it. Then what I do, I scan it and I get a printed model, and printed model make a pull down and make a special type of pull downs. That's 2 parts. That makes it easier for me to build. So what I do is I can initially build a lingual platform, and then I'll build the rest of the labial platform, or do the whole thing in one go, and I'll separate them. So there's a number of ways to do it. I could also build this and restore this freehand as well from the scratch. So I don't have a problem with that. But if you're starting out initially, you can even do a wax up. But then again, if you do direct mock-up, you've already tested the system in the mouth. You know how much to build. You can trim it and shape it. You know what it's going to look like. So when you transfer the model, not much of wax up is required. And that's how we do it normally on this particular patient. So sometimes we think of doing a diagnostic wax up, then you transfer it. It's an extra step. That extra step I don't need. I don't think you don't need either. So in the college, we show you how to do a direct mock-up. And Nimesh was absolutely right to mention this, because direct mock-up determines, because live patient in front of you, you do a direct mock-up, which is called real smile design. And like any digital smile design, I mean, what the heck is that? What does digital smile design really mean? You get the patient, take their thorax, a digital smile design, then you're just a technician, right? You haven't created a smile in the mouth that can test the system. And people like to look at their teeth when you do diagnostic mock-up. They really want to look how good it's going to look. So I think the most important thing, you need to understand that patients need simple and effective treatment. If you can simplify the treatment, and that's one important part of the diagnosis, that I like to explain to the patient, what is it that they really want? If they want something simple, well, we'll tailor the treatment needs and our treatment and our assessment to what exactly they need that makes them help them. So the answer to the question is, the part of the concept is, patients do not want implants. They just want comfort, function, and aesthetics. And when you look at a patient having looked first time in their mouth and how they look, it really astounds you sometimes, because it's happening to those patients regain their youth, and they look younger, the hairstyle changes, and they're much better. And it's very important that we help this patient to achieve a desired outcome with minimal cost and almost no biologic intervention. So if you decide to place someone having implants and overdenture or etc., which is an absolute option as well, that's fair enough. But what about if the patient could get accustomed to the thickness of the acrylic overdenture? And I'm seeing a lot of patients now coming through my surgery, and they have this all-on-4 procedures done without any initial preparatory phase, and they can't get used to the block of acrylic in their mouth, and they are in a terrible state. So a lot of them have removed the block of acrylic in their mouth as a result of all-on-4 treatment, and they're walking around without teeth because they feel more comfortable, and that's a serious issue. I'll probably discuss this at another time in terms of helping this patient to achieve their desired outcome. So this particular, any questions so far? No? I'll go next slide. It's probably the last slide here, which I'm happy to go. And the last slide is, you can see before presentation of the patient, and not only we improved this patient, but also we improved the function, we restored the facial height, and we really changed this person. So simple treatment, effective treatment, one visit, and you change people's lives. So taking home points is the fact that think outside the square. Think about what could be a simpler treatment that will do the same thing as a complex treatment, and the cost savings to the patient. Also, the more complex treatment naturally is more biologic intervention, more financial cost. So a simple treatment you have time, you have contingency planning. If you break a restoration, or if any of these build-ups breaks, that's fine, it's a restorative failure. But if you break a restoration and you break a tooth, it's a non-failure restoration, but it's also a failure of biology. And for this patient, you're able to restore their confidence, give them hope, minimal financial outlay, almost zero biological information. And to me, that's what dentistry is in a specialist practice. And this can be same in your general practice. You see these patients come in your practice all the time, and they want simpler solutions. You know, this was a simpler solution to a very complicated problem. But the answer to this is that the solutions are there. So, when we tell our patients that major reconstructive work done, in this particular case, it's failed because the dentist hasn't taken into account the fact that they should test the system. Then when they see these cases, they get very much upset because this was available and they weren't given the option. So as a clinician, it is our duty of care to get an opinion if they're not comfortable with it, but also give them something simpler and they'll be able to, have that treatment in the shortest possible time, get them back onto their livelihood, they're back on so their lives are not on hold, and they're happy. So, that's what I do every day in my practice. And I hope you enjoy this webinar number 3. If any questions, I thank you for participating. Any questions so far?
Dr. Sarkis,
yeah,
had a beautiful transformation. I think the patient's so happy. My query in my mind is always, I know the patient trusts the clinician and they come with a financial concern.
Mm-hmm.
How would you, because how would you help them to understand whichever price that you are proposing for these, and how would you respond to their question on the warranty or post-treatment care until they are ready for the more definitive treatment? Thank you.
Oh, good question. I think the most important thing for me when I write this to the patients, I tell them this is interim restoration. In other words, we can extend from time to time the longevity of restoration by resurfacing with composite. If they chip in the next 2 to 3 years, we have to repair them, but they have to be within the system. But most importantly, when we talk about the preparatory phase of this patient, is in my last lecture I talked about the most important was the maintenance program. So the maintenance program is most important. So I didn't write maintenance program because I talked about a lot about it in the last lectures. So they have to adhere to the maintenance program. Because I will not start as part of the consenting process. So when we talk about consenting here, the maintenance program is the most important part. So look, you know what? This is, you worn your teeth down, you've broken your teeth, I'll put stuff on your teeth that will break because you actually broke your own teeth. You wore your teeth down. So that, if you want major work, I still couldn't do this unless I do this part of the work as well. So you must come in every 3 months initially and every 6 months for the next 2 years for me to feel comfortable before I proceed any further. In the meantime, we know when composites, we can maintain this patient like this for the next 5 years, no question about that, by resurfacing every 2 years, for which there will be still a fee naturally to do, because they're where the composites are. But mind you, with the new composites, with the micro hybrids, not nano hybrids, the wear is fantastic. So, EchoSight is fantastic wear. It's very good. I get EchoSight from DMG. DMG, that's a Good's product. So it's a very good. One thing about the EchoSight is they actually place the contact points and maintains those contact points. That's really good. So maintenance is the key to a good outcome, and that's really, really important. Thank you for that question.
Thank you.
Dr. Sarkis?
Yeah.
If the perio of condition is somewhat questionable and if she needs periodontal treatment, would you think differently in this case?
Absolutely not, because if they need periodontal treatment, okay, let's assume that lower anteriors, there was a grade 1 mobility, right? Even there was a grade 2 mobility, one thing you do is you understand that in this particular patient here, okay, I mean, let me ask you a question. What is an occlusal trauma? Anyone can answer, what's an occlusal trauma? Is this an occlusal trauma? I would say yes. Is this a primary or secondary occlusal trauma? Any answers? Isidora.
Say again, sorry, Sarkis, was that, is this occlusal trauma?
Would this be considered as an occlusal trauma?
I would kind of monitor.
Well, you can see it, it's fracture, right? This is a trauma. Definitely, it's a trauma.
Definitely trauma. Definitely bruxism.
That's right. No,
trauma. Yeah.
That's right. If, let's say, this tip was mobile, would you consider this a primary or secondary occlusal trauma? The question is, what's a primary occlusal trauma? Anyone can tell me what is a primary occlusal trauma? Anyone can look it up for me? Come on, go to your Google. So what's a primary occlusal trauma? Kathy.
I'm Googling right now. I was.
Let me help you. Let me help you. Primary occlusal trauma is when you do a restoration, it's high. It's just it hurts. Okay? That's a primary occlusal. What's a secondary occlusal trauma? Is when a tooth is mobile and it's subject to occlusal forces. That's where we get drifting, okay? And orthotic movement, right? So if there was a secondary occlusal trauma, the first thing I would do to my dear colleague from Prudential Dental would be to split those teeth, and we reduce the occlusal plane for this patient. What do we mean by, what was the aim of reducing occlusal plane? I reduce the plane here to do a number of things. First, level the occlusal plane, shorten the root, which improves the crown to root ratio. Is that clear? Okay. So you're reducing crown to root ratio, so it's less mobility. So it's all factoring into account what we do. That's why whenever we do treatment, you have to understand, doctor, what is the rationale behind your treatment plan? So someone's like, a case, I just can't believe it. So I ring my colleague and tell me something. What was the rationale behind your treatment planning? Oh, what's wrong? I said, nothing, I just don't know why you do it. I'd like to know why you did it, because maybe I don't know. So that's how we have to think. What is the rationale behind the treatment plan? So rationale is, as I tell my patients in my letter, that this is the rationale. The reason I need to do this because of these factors. It's written in plain English. So if that was still, unless you reduce mobility, then you splint the teeth. When you splint the teeth, you immobilize it to a certain degree, and you improve comfort, and you can carry on do it. But naturally, you have to do periodontal therapy. You have to do initial pocket measurements. No periodontal measurements, no X-rays, no nothing. You can't just restore teeth. So all these diagnostics is into account. I will extend the length of the slide as I avoid them, but here you are. We have improved the crown to root ratio. We reduced it. Smaller crown to the root. And now I'm able to rebuild this patient. That's it. Okay? And then there's a minimal teeth here remaining. We need to build them up. So from that point of view, if patient had periodontal disease, it was all effective periodontal disease. If she had gum disease from one end to the other, I can assure you, I have never seen a bruxing patient, and the patients got periodontal disease at the same time. It's lethal. They'll lose all their teeth. I can assure you. I can assure you, they will lose all their teeth. And in many ways, that wouldn't be the case in here for this patient. So periodontal patient, treat the perio, split the teeth, reduce occlusion trauma, and naturally in this particular patient, if she had periodontal mobilities on lower anterior incisors, that's because of most likely of like more of a primary occlusion trauma, because occlusion trauma and probably poor plaque control would have created a secondary occlusion trauma. So leveling it, opening it by, you're reducing the forces. What you're doing is redistributing forces to the adjacent teeth. Now we have a shortened and enlarged can function on its own, which meant the dentures to make it more viable as she prefers. But she can function as it is, being the sort shortened and enlarged. I hope you're happy with that answer. Is there any other questions?
Did you build the denture surface for the back teeth, or you just let her keep going with it?
Here, there's a denture. See that?
Oh, okay.
And there's a denture here. There's a steel clasp just on top of the veneer. So okay. What you do when you do a veneer, you make a little ledge there. Veneer just the clasp just clicks it.
Yeah. Good. And this preparatory phase, we don't need to look at the time frame for it, isn't it? I mean, if it keeps going for 5, 6, 7 years, then let's just keep going, isn't it?
I wouldn't go 5, 6 years. I mean, that's very good thinking. But this patient's, I would say within 3 years, I was going to say, well, we have to do something about some of the posterior teeth. We did the crown. So what I would do in this case, I would crown all the premolars, all the I would say, I'll leave the anteriors. I'll crown the canines and back molars. And maintain your occlusion vertical dimension. So, and then the rest of them will last very well because you're actually loading those teeth and they take the load in guidance, etc. You can do a lot of things. You can create thicker composites. You can create platforms. This is not a dial effect patient. We're going to talk about the dial effect next seminar in 2 weeks' time. But this is the sort of thing that I really would do every day. And this patient gone for a long time, a long time.
Cool. Thank you.
Thank you all, and thanks for coming to this presentation. And I enjoyed all the questions. To all of the participants who have to sort of come in and answer questions. If there's any more questions, I'm still happy to answer. No question? Going once?
Is there any acid wear on this patient at all? Acid reflux?
Say that again, please.
Sorry, was there any acid reflux on this patient?
Yeah, we did gore testing for her. No, there wasn't any acid reflux on her, but you would say could have been a history of gore. That's a good question. That was all taken into account. Good history taking will give you a lot of answers to this patient. And that's one reason we did rim lamination therapy for about 6 weeks before we started treatment. Good question. Would I do an occlusal splint for this patient? I did, but she doesn't wear them, like they don't. So the answer to the question is, you build your occlusion as you don't know how to wear occlusal splint. Don't rely on occlusal splints. No one wears them. Only very few patients who wear them. So build your occlusion that you can maintain without the patient wearing an occlusal splint. And that's the key to your occlusal prescription. Okay?
You remove the reason for clenching.
I'm sorry, man.
You removed the reason for clenching. You gave her a beautiful teeth, so now she's not clenching.
Exactly. You just reduce your good forces, that's all.
Yeah.
You reduce your good forces. I mean, you restore the profile. She's class 3 skeletal profile. There you restore the class 1. I mean, a lot of changes. Looks good. That's what you. So people are more comfortable when they look good. They feel good. They'll be more receptive to change. So I presume, so you get away from occlusal splint. The chance that they will, but at the age of 67, will she change? I don't know. But we did make it for the insurance policy. Oh, did you make a occlusal splint? Yes, I did, but she's not wearing it. And that's something to consider. Thank you very much, group. If there's no questions, I shall call it a day, and thanks for tuning in.
Thank you, Dr. Sarkis. That was fantastic.
Thank you very much.
Thank you. Thank you. All the best. See you in 2 weeks.
Thank you, Doctor.
Thank you.
Thank you.
Thank you.
See you Friday. Bye.
Bye-bye. Thank you.